Assaf Ha'rofeh is going to be our first partner in transforming both in Israel and globally. And we are very happy that you took the initiative. We would like to participate in this journey. We would like to experiment in new trends at Assaf Ha'rofeh. And with your leadership, I'm sure that we can start to march in this very important journey of transforming lean healthcare and make a big tikkun olam for ourselves. So we claim that.
So it's a pleasure to be here. What I'm going to report to you on, 8-9 years ago, I was in the White House working on the Affordable Care Act and creating health care reform in the United States. And then after enacting that in January 2011, I left to the University of Pennsylvania and began a multi-year study of health systems in the United States that are really doing outstanding work, really performing very well, very, very high quality and very low cost, and try to identify what activities they're doing that are transferable to other systems. Obviously, my focus was mainly the United States, but hardly only the United States. Every developed country is facing the same problems: high healthcare costs, aging population, and I'll talk about the differences. So I like to begin all my talks with these are American dollars, not worth that much anymore, but with costs. In the United States, we spend $3.4 trillion on healthcare. Now, this is a very smart audience. I know one thing 100% for sure. You have no idea how big $3.4 trillion is, because when I was working in the White House, I worked for the only organization in the entire world that dealt in trillions of dollars, and that is the Office of Management and Budget. That's the part of the United States government that controls the entire federal budget. It's the only thing that is bigger than the American healthcare system that you and I know of. So to put in context how big this number is, I like this chart. This is GDPs in the entire world. So the United States still has the largest GDP in the world. China's 2, Japan, Germany. But the American healthcare system is the 5th largest GDP in the world. We spend more money in healthcare in the United States than Britain spends on everything. Those great universities of Oxford and Cambridge, all the Queen stuff, the crappy food, haggis, and whatever else they eat, right? We spend more in the United States than Britain does on everything for its 60 million population. And notice, you know, in a few years, by the end of this decade, we will spend more than Germany. We'll be the 4th largest GDP in the entire world. We once, in the last 4 months, did this, which is affordability in the United States of healthcare. Now, the United States is a terrible problem, but we took health insurance costs divided by the median income, and you can see this tremendous increase in health insurance taking out of the family pocket. 1/3 now of the median income in the United States goes to healthcare. One of the things you can see also, I don't have a pointer, but is from 2011 on, basically flat. That's because of the Affordable Care Act. It's basically been flat after the Affordable Care Act. We actually were able to control healthcare costs. Now, that's how much we spend. Here's how we perform. This is life expectancy versus healthcare spending on a per-person basis. Beginning in 1970, right? This is life expectancy. This is health expenditures over time. And you can see, basically, in 1970, every country was in the same place. Spending, you know, $500, $300 per person, and life expectancy was about 71 years. And then you run the film, and you can see that the United States, I don't know how many pediatricians in the audience, but I like to say the United States fell off the growth curve, right? This is the growth curve of normal, right? We fell off. And I point out to American audiences, you know, you see up here, we're even worse than Greece. You think Greece is bad? basket case in terms of finances, Greece has done pretty well. We are terrible. All right? Now, lots of American health policy experts say life expectancy is a terrible measure of how a healthcare system does, right? Lots of things affect life expectancy. You know, birth, physical activity, eating, social networks. So I'm happy. There are many other measures of health performance, and again, the United States measures terribly. The important point is that the difference between the United States and, say, France, or the United States and Israel, it's not some master gene that the French know and we don't know anything about. It's not some high-tech equipment that the French have and the Americans don't have. And it's not some new drug that the French have and the Americans don't have. So it's none of the high-tech medicine that makes France better.
They just have the gene.
Huh?
They just have the gene.
The difference, and it's not that either. The difference is how we deliver care, and the how we deliver care is the responsibility of all of us who are in the healthcare system. And I don't think the United States is a bad outlier because we spend so much money, but there's no healthcare system in the world that is high-performing on a consistent basis. Even high-performing France, which gets ranked often #1 by the WHO, has many, many, many problems and inconsistencies. So what are these problems and inconsistencies? Again, I don't know the details of the Israeli healthcare system. Unless you are uniquely better than anyone in the world, right? These problems are going to be consistent. One is we deliver a lot of unnecessary care. And again, I don't know the particulars of Israel, but if you look, this is a graph from Seattle, and you look at different places delivering care to patients with breast cancer, women with breast cancer. And I think Boaz mentioned I'm a doctor, but he didn't mention that I'm an oncologist. And so I see the entire healthcare system through cancer. I know a few other things, but cancer, cancer, cancer. And because it's so expensive and so feared, it's a very good model. And because it requires surgery and chemotherapy and radiation and end-of-life care, it's a very good model for integrating care. This is PET-CT scans ordered for women with early-stage breast cancer. It's small breast cancer. All the guidelines say you should never order PET-CT scans for these women because their chance of having a distant metastasis is essentially zero. You will not pick it up because it's too small. And you can see huge variation in clinics around Seattle. Some do 80%, that's 8 out of every 10 women get it in a test that they should not get, down to just under 10% at the best clinics in the country. I don't know how much a PET-CT scan costs in Israel. The United States average costs $6,000. Totally unnecessary care. Right? Go to America. So this is, anyone know what this is? It's proton beam. Proton beam. We now have, 22, 26 facilities for proton beam in the United States. Proton beam is indicated for one situation, pediatric brain and spinal cord tumors. In the United States, we have 9,000 cases a year. Could be good for maybe 3 proton beam facilities. We have 25, 26 of them. It depends on which ones are in bankruptcy. So to not go bankrupt, what do? They treat prostate cancer, they treat breast cancer, they treat lung cancer with no evidence. Zero evidence is better. Certainly more expensive, no better, called inefficient care. Here's another one. I told you I'm an oncologist. This is radiation for bone metastases. If you have a patient who's got a breast cancer or lung cancer, single bone metastases, lots of randomized trials showing 1 zap with radiation is as good as 10. And you can see here the number of places that give you 1 treatment only. Most are giving you many more treatments. No better. Not better in longevity, not better in pain relief. Why are they giving 20 treatments or more? Kesef. Because we get paid in America every time we press the button. So if you press the button 20 times, you get paid a lot more than if you press it once. So, totally inefficient care. And yet, you can see the vast majority of patients, whether at hospitals or at freestanding centers, we have a lot of freestanding oncology centers, totally inefficient care. This is another one, breast radiation for women after lumpectomy, right? 4 independent studies from around the world, not just in the United States, and they show you that 3 weeks of more intense radiation is equivalent to 7 weeks of regular radiation. Whether you're looking at survival, recurrence of disease, or cosmetic result and how the breast looks. Exactly the same. And yet if you look in America, 2/3 of the women get 7 weeks of treatment, and you look at Britain or Canada, I don't know what it is in Israel, 70% get 3 weeks of treatment. What's the difference? Paid for every press of the button. So you get paid for the press of the button, you'll do 7 weeks instead of 3 weeks of treatment. Inefficient delivery of care. 7 weeks cost about $19,000 in the United States, and 3 weeks cost about $14,000. It's a substantial 50% price difference. And then there's lots of pricing failures. Again, I don't know Israel's situation, and maybe it's better, but the United States, if something's done in a hospital, you get paid a lot more than if it's done in a physician's office, the exact same thing. And this huge price problem, it's worth about $105 billion. So, unnecessary care, inefficiently delivered care, and pricing problems in the United States, we estimate, are worth about $500 billion in waste. $500 billion, right? That's 15% of all healthcare spending is totally without basis. So we passed the Affordable Care Act almost exactly 8 years ago. I like this picture because this picture is taken right over my head. The camera was right behind me. And if you were Americans, I would ask you, many of these people are famous, or should be famous to Americans, but there's one particular person who no one knows. The person who's standing closest to the president. This man. All the other people, famous politicians. That man, no one knows who he is, and no one knows why he's standing closest to the president. It's a mystery. So I just want to show you how good the Affordable Care Act has done for the United States. This is the number of people without health insurance in the United States, and you can see a substantial drop right after passage of the right after enactment, putting into place. You can see among children the uninsurance rate's gone down, and you can see among adults. This is costs. This is per person costs in the United States, and you can see again 2010 right after passage to 2014. Actually, in government programs, negative costs per person, saving money. This is most recent cost expenditures. The red line is the GDP, and the blue line is healthcare costs. And you can see they track except for one period here, 2015, 2016. Anyone know what happened in 2015, 2016? Any hepatologists in the room? Huh? It's Sovaldi, right? The introduction of Sovaldi at $1,000 a pill in the United States. Measurable increase, just one drug, measurable increase in spending. Right? Here's the reduction in unnecessary hospital-acquired infections, falls, bad medications, because of policies that penalize hospitals for infections or unnecessary services. Estimated 125,000 fewer deaths. When we were trying to pass the Affordable Care Act, Republicans would say it's going to kill jobs. You're going to make people buy insurance, it's going to kill jobs. No evidence had any effect on jobs. And this is, I think, the most interesting thing. I don't know what you call VC in Israel. Probably they have a very bad, nasty name. But in America, we often say that they're either vulture capitalists or they're smart money. And they can be both, vultures and smart money. But this is what smart money has done. Before enactment of the Affordable Care Act, $47 billion was going into new companies after a 30% increase in spending because they realized that there are many opportunities to innovate in healthcare and innovation not just in drugs and devices, but this is in processes of care, making care more efficient, introducing improvements in the hospital. All right, so as I mentioned, I went around the country to look at different systems that were doing very, very well. In general, despite telling you how much money we're wasting and how bad the system's performing, I am wildly optimistic about the American healthcare system. Wildly optimistic. Anyone know anything about Stag's Leap wine? Anyone like wine? No wine lovers? What kind of organization are you running? So in 1976, anyone old enough to remember 1976? There was a London wine merchant named Steve Spurrier. And he wanted to find out, are California wines better than French wines, or French wines better than California wines? So he got wines from both, the best wines from California and France, and he did what's called the Challenge of Paris. He brought them to Paris for a blind taste testing. There were 13 judges. 11 were French, 1 American, and himself 1 Brit. Blind taste testing. And what do you think happened? Stag's Leap won. Best wine in the world, blind taste testing. And what do you think the French said? They took it quietly? No, they were outraged, right? It wasn't blind, there was cheating, whatever. And then they said, you know, the French wines will age better. So I think it's 3 years or 4 years later, they rebid the Challenge of Paris. And what happened? The Americans won again. What does that show you, in my opinion? If the Americans focus on something, and they want to be the best, they will be the best. We are very entrepreneurial, very innovative. We develop ideas. We know how to commercialize ideas. Very, very important talent for improving a healthcare system. And it's not just wines that this has happened. Beer, you want to get the best beer in the world now? We've got literally tens of thousands of microbreweries doing phenomenal beer. Olive oils, we've now got phenomenal olive oil out of California and Texas and very strange places. Cheeses, the same thing. Do you see that chocolate there? That's my chocolate. I made a chocolate from Madagascar. Fantastic chocolate. You can buy it too off the web. My point is that we will, over the next 15 years, develop a really high-functioning healthcare system. So what I've done is to go around and find out what are the characteristics of that high-functioning healthcare system going to be by looking at places that were already doing it. And identified 12 different changes necessary for a high-functioning healthcare system. Everything from how you schedule patients to how you register a patient in an office and room the patient to shared decision-making about do you really want your hip replaced or your knee replaced or your heart surgery. Performance measurement for doctors. It's here, coming, and going to be everything you do. Standardization of care. Should not be by doctor. Today I feel like. Care management for people with chronic illness. Changing the site of service. Moving patients out of the hospital. Deinstitutionalization. Behavioral health changes. Hospice and palliative care. Improving care at the end of life by moving it more into the patient home and not just in the last 30 days. Community interventions by working with people who are disconnected. And then, last but not least, behavior issues. What is the big challenge over now in the next 15 years to get these things realized? It's behavior change. Behavior change for patients. Diabetics need to do better in managing their weight, in what they eat, how they exercise their insulin. And it turns out healthcare providers need to do better because we are not performing very well. Maybe doctors here and nurses here are outstanding every time. I'm willing to bet a lot of money not. I bet lots of dinners. I'm very famous in the United States for winning bets with Supreme Court justices and others. I'm willing to bet lots of dinners that things can be improved substantially. So I can't, I forget how I can go back. I can't deal with all 12. I'm going to talk about 3 that are very, very important for changing practices. So, in every developed healthcare system in the world, that's good system in a rich country, 84 cents of every dollar, roughly, is spent on patients with chronic illness. 84 cents of every dollar. Chronic illness means you have it every day. One of the things it means is managing you in a hospital is a bad mistake. Because hospitals are about acute care, not chronic care. And if a patient with chronic illness gets to the hospital and is using the hospital for everyday care, it's totally a mistake of the system. So one of the things that has to change is chronic care coordination. Actually managing these patients on a regular basis when they're at home. So I want to take you to, you know the map of the United States? I want to take you to Texas, and Texas goes like this, right? As a tippy point where it borders Mexico. That's the Rio Grande Valley, RG, Rio Grande Valley. This was a group of doctors that was performing terribly. The community was very poor, mostly Mexican immigrants, spoke English very little, low education, lots of unemployment, and 45% of the adults had diabetes. Whoa. Their usual mode, their sugars went out of whack, they called an ambulance, went to the emergency room, got admitted for a day, stabilized, sugar fixed, sent home. 2 weeks later, same Bubba Mites. Right? So under the Affordable Care Act, they got money and an financial incentive to bring in a chronic care coordinator to work alongside the doctor. 1 in each office. They had 4 offices, and at their big office, 2. And they worked with the patients. First thing they did, don't call the ambulance, call us. Second thing they did is they began working with them to focus on taking their blood sugar regularly, taking their insulin regularly, and telling them why it was important, and then doing several other things. So chronic care coordination is very important, as I mentioned. 84 cents of every dollar, and certainly in the United States, and I'm sure it's the same in Israel, spent on chronic care. Patients with chronic illness are spend 4 times more than the average adult. They utilize many more services, and they have many more limitations in their regular lives. And they tend to be disproportionately older, female, and less educated. Every place that has transformed this care that I looked at, and this is the first thing that everyone did 5 things. First, you have to identify your high-risk patients. Patients who are using the system a lot or likely to use the system a lot. It's interesting, you talk to people who aren't involved in healthcare, not doctors or nurses, and how do you identify patients? You do big data, you get an algorithm, and you do machine learning. Baloney. Turns out, not very important, lots of money, and not that valuable. You ask the doctors and nurses. They know 80% of the patients who are expensive, using the system a lot, and a better intervention could keep them at home. 20% they don't know, because while they're supposed to care for them, they don't come to the office, they just use hospitals or other facilities. And so the algorithm can help on 20%, but for 80%, it's just the good old medical intuition, clinical understanding. But you need to identify those patients. Some places give them a score, 1 to 4. Some places have what they call a war board, where they list all the patients for the doctors to see. Often they have just been in the emergency room or just been at the hospital. Second, and this may be the most important thing, they take a care manager, not a doctor, sometimes a nurse, but often just a medical technician or health aide, and they work with the doctors and nurses on these patients. Their responsibility is for the sickest patients to call them, know them, know everything that's going on with them, often see them in the office. These care managers are empowered to what we call close care gaps. Do the things that we expect all patients to get. You expect the hemoglobin A1C on a diabetic patient to be measured every 3 months. They make sure they get measured every 3 months. You expect them to get a flu vaccine. They make sure they get a flu vaccine. Once a year, they need, eye exam. They need toe exam, foot exam. Care manager is the person who makes sure that happens, arranges it so the patient doesn't have to arrange it, and make sure they show up. That's the point. They use active outreach. One of the biggest problems of every healthcare system is, when do you see a patient? When the patient calls you. Care management doesn't wait for the patient to call. It calls the patient. It's active outreach. It's proactive, anticipatory care. This improves compliance. It also improves social interaction and prevents complications. And the last thing those care managers do is they educate patients about their illness. Often they don't understand what a hemoglobin A1C is. They don't understand how important it is to control their blood sugars, or to control their blood pressure, or to control their weight, or what's causing their weight gain. Get them to adhere and also get them to change their behavior. This is the CEO of one of the best places in the United States. CareMore is based in Los Angeles. It cares for only very, very, very sick older adults, patients over 65. That's their exclusive. They save about 30% of costs. And he says our number one complaint is that patients hear from us too much. Their outreach is so much that patients hear from them all the time. We're trying to streamline the calls and the appointments so you know that you're getting these high-risk patients in early and often. This group is so progressive. One of the things they do is they tell their diabetic patients, don't cut your own toenails. Come in once a month, we'll give you a pedicure. Right? I've heard pedicures are nice. I have never had one, but I've been told they're very nice. What happens when they bring a patient with diabetes in to get their toenails clipped, the feet rubbed and washed? What does a patient do? I don't know. But one of the things they do is talk. It's much easier to talk when you're getting a pedicure about your problems, what your stressors are, why it's hard to adhere to your medications. And they find this incredibly valuable to figure out when something is going wrong with patients and they need to intervene with them. It's free, right? But the information is priceless, right? Like Facebook, free but very valuable information. Second thing I want to talk about is scheduling. This is my own personal saga with my primary care doctor. Now, I like to think of myself as a big macher at the University of Pennsylvania. I have a very fancy title called Vice Provost for whatever, right? I'm his, President, Provost, Vice Provost. That's where I am. And most people know my name. So I have a very high-tech ability to make an appointment by emailing my doctor. This is how high-tech American medicine is. I can email my doctor, right? So I email my doctor, I have a kidney problem, maybe we need a checkup now. Should I get the labs before I come? So I email my doctor to assess my kidney function. The next day, the nurse emails me back, yeah, we can schedule an appointment for you, and by the way, the next available appointment is 7 weeks. I think I'm a big mocker, but I don't say anything. I said, okay, I'll take 7 weeks. My doctor finds out, and he's very upset. So he emails me back, and he says, just call anytime, and I'll double book you. You know what double book is? I have one patient, and I add another patient on. Double booking? The worst thing you can do. Why? Doctor feels like he's running around, and both patients hate it, right? The patient whose regular appointment is shortened to fit me in, and me because I think I get a short appointment and he's not paying attention. Everyone hates it, right? So I double book. How fast? 3.5 weeks. That's the speed, right? Finally, after 27 days, I see my primary care doctor. This is scheduling in America. Israel, I am sure it's better. Of course. Mea chuz.
If you were a big macher in Israel 2 days ago.
Yeah. it turns out appointments and scheduling, when I started this project 5 years ago, I would have never said appointments, very important. Never thought about it. Turns out it's maybe the second most important thing to chronic care coordination. Having appointments, changing the scheduling. This guy, Simeon Schwartz, runs WestMed, which is a big 360 physician group in Westchester County, New York, so just north of New York City. Simeon Schwartz, and he also is an oncologist, but he's funny, and he says the appointment book is the holy grail of transformation. For physicians, autonomy is synonymous with the scheduling book. Controlling time, right? What do physicians sell? They sell time, and controlling time is critical. It took him 2 years to take the book away from the doctors, and then he had a call center where patients could call up and then email. Where was the call center? He put it in North Carolina. No doctor can get at it. They have their own algorithms in North Carolina. The old system is physicians control the appointment book. Slots are either double booked, left open so the physician can go golfing. I know you don't golf in Israel, but go to the beach and surf, right? Or filled with patients that they like seeing. The easy patients, the patients they like talking to. Patients who need to see the doctor, they call to the nurse then talks to the doctor, they negotiate, everyone's negotiating to see when they can double book. The new way is, let's think about the patient, right? You got a problem, when do you want to be seen? Now, right? I want to be seen now, and I don't want to wait, by the way, when I get to the doctor, right? Take the appointment book away from the doctor. Every day, 25 to 50% of the slots, and there are some consultants recommend 70% of the slots empty. You start on a Monday morning, and half your book is empty, right? Now, my father was a pediatrician. If I told my father, half the day you're going to start, every day you're going to start, and half the day is going to be empty, he would have said, no way, right? I'm going to lose money. People aren't going to show up. It's going to be terrible, right? Totally wrong. One of the other things you do is you keep appointments on Mondays and the day after holidays. More appointments empty because patients get sick. I like to say, when I was training, when I was intern and resident in the United States, I would always say, I'll take Christmas. I'll do Christmas Day, right? My non-Jewish friends, they wanted Christmas Day off. They would be with their family. For me, it meant nothing. I do Christmas. So my kids would come into the hospital. We'd watch a few movies. We'd play some games, right? Nothing would happen on Christmas. No one ever gets sick on Christmas. When do they get sick? The next day. So I'm on vacation. They're working their tails off because they wanted Christmas Day off. It's probably like Yom Kippur here, right? No, Yom Kippur, the hospital is quiet. No one ever gets sick on Yom Kippur. So, what do you change? You get rid of scheduled appointments and you have them open so that when someone calls, you can literally say, come in at 1 o'clock and the doctor will see you for a regular appointment. What are the benefits of this scheduling? First of all, the doctors can see today's problems today, not in 6 weeks. You decrease patient waiting time in the office. If I know at 1 o'clock I will see the doctor at 1 o'clock, not at 1:30, I'm there at 1 o'clock. It turns out that one of the things doctors don't think about is how many of their patients don't show up. Turns out lots of patients don't show up for their appointment because, for me, I make an appointment 7 weeks from now, and who knows what's going to come up, right? Different doctors, different things. 20 to 25% no-show is a very common number. Patients love it. You tell them to show up at 1 today, they show up. Staff turns out to like it. No longer complicated negotiations, everyone mad at them. And it also turns out there's less emergency room use. Oh, sorry. Damn, I don't have the other slide. We worked with an oncologist to have this open scheduling. Their emergency room use went down 70% with same-day scheduling because patients with side effects from chemotherapy, you didn't say send them to the emergency room. They had empty slots. They could see them, whether for vomiting, itching, diarrhea, or whatever. and they don't have to use the emergency room, which is quite expensive and very, very inefficient, slow times. The last thing I want to talk about is standardization of care. This is generic drugs ordered by doctors in the University of Pennsylvania Hospital. Okay? What do you see? Chaos, right? Everyone's ordering different things. There's no order. We changed so that when you order a medicine, automatically, without you, automatically, you can't order a brand name ACE inhibitor. You get the generic. You can change it, but the automatic default is a generic, even if you ordered by brand name. You can change it again. And what happens? You get 100% generic, except for one drug. Anyone know what that drug is? Might be? Huh? Thyroxin. Right? Thyroxin is a drug where the generic and the brand are not interchangeable, that there's problems with the brand. Right? They're not consistent amount of thyroid. Right? Everything else, why is that? You know, this year's Nobel Prize for economics was for behavioral economics. What does behavioral economics tell about people? Fundamental discovery about people. We're all lazy. Right? You tell us to do X. We'll do X unless we have a real big objection to it. Right? If the government takes, if your employer takes out of your paycheck 3% for pension, right? You won't object even if you could change it. Everyone gets 3% if that's what happens. Right? You go to countries for organ donation, you don't ask people, do they want to donate their organs? You tell them, all organs are going to be donated unless you object. How many people donate organs? 90+%. You then, on the other hand, countries like the United States have asked, do you want to donate your organ, yes or no? What do you get? No, you get about 10 to 15% say yes. Right? Just change the default. Because we're lazy, we'll do whatever the default is. Doctors and nurses, no different. Change the default. Very important to standardize care. Again, this is WestMed, and they standardize protocols, and they build those standardizations into the electronic health record, and they use a 4-prong approach. First, they say to the physicians, they don't say, here's the standard. They're going to say, you pick what's important to you, and you standardize the protocol. So, management of atrial fibrillation, they said to the cardiologist, what's the best protocol for managing atrial fibrillation? Then they put that, they make it an algorithm, they put it into the EMR, and then they measure physician adherence to the protocol and the actual outcomes of patients. And then they tie bonuses. In the case of the United States, we can give money. Other places don't give money, they give non-financial bonuses for how frequently they actually use the protocol and how frequently they don't. And you can see, when they implemented it for hypertension, they improved good control, that is, between 120, below 120 over 80, from 77% to 84%, where the national average was 50%. So they already started out with very good doctors, and they were still able to improve it 10% by standardization. Here's another oncology group we worked with. This is 9 oncologists outside of Philadelphia. One of the big problems of chemotherapy is mouth sores. A lot of chemotherapy give patients mouth sores. Among 9 patients, they had 4 different ways of treating mouth sores. So it's a problem for the nurses. Which one is this doctor like, this protocol, which wash or whatever. So they sat all 9 oncologists down and they said, all right, how are we going to manage mouth sores? Pick one protocol. And then they standardized the protocol, so everyone's treated the exact same way. It reduces mistakes that the nurses make, increases adherence, and saves money because they don't have 4 different chemical gamishes that they use. Just one. So what are the benefits? Ensures the highest level care that the doctors and nurses have decided this is the best care, consistently provided. Second, it promotes effective teamwork between doctors and nurses, so no longer guessing and negotiating. Translates the standards into standard orders so things can be automated. and enables innovation when you see if you're not meeting target. Then you can change one thing in the standard protocol and see. At Kaiser in Washington, D.C., they have to get a patient screened and properly managed for hepatitis C and on the right medication if they have it, it's one order. You just check the box for standard hepatitis protocol, and they have one algorithm for all patients. So everyone gets treated the exact same way, and it's not missed. The doctor does not miss, doesn't have to reorder every individual test. If you integrate standardization, scheduling, and care management, you get a very effective way of managing patients with chronic illness. Because you have chronic illness and exacerbations, patients are told if you have a problem, you've got congestive heart failure, you're short of breath, call early in the day, we'll put you in that day, right? And we'll run you through a standard protocol. This is very, very good management. Again, mainline oncology did this for chemotherapy side effects. There are 18 common side effects of chemotherapy, things from fatigue, to bruising and bleeding, to infections, to nausea, vomiting, diarrhea, nerve damage, anemia. And again, they vary. The National Cancer Institute has protocols for managing each one of them. They put it on a computer. They told patients, if you have any one of these problems, you call. The nurses then pick up the phone in the morning. They run the algorithm. If the nurse identifies a problem, they bring them into the office. Most problems, over 75% of problems can be handled at home for the patients. Very few go to the emergency room. All without lots of doctor intervention except for the most extreme cases. So nurses are educated to use the algorithms, respond to the patient. Patients were encouraged to call early, not wait till 4 p.m. to call. 30% of physician and nurse appointments each day were kept open for patients to come in that day to be managed. Here's the data of the outcomes. You can see 77% managed at home, right? 5% had an office visit. 5% went to the emergency room. And here's the decline in their emergency room utilization because of this combination of standardization, scheduling change. They went from 2.6 emergency room visits per 100 patients down to 0.81. Decline of 2/3. Huge amount of, and it's better for the patient. I'm managed at home, I'm not going to the emergency room, I'm not taking my time. Patient experience is just much better. All right, I'm going to end by talking about virtual medicine or digital medicine, right? It's the big watchword. Everyone thinks they're going to do digital medicine and have a digital intervention. Eric Topol is one of these big advocates. He said, over the past decade, smartphones have radically changed many aspects of our everyday lives, from banking to shopping to entertainment. Medicine is next. Just as the printing press democratized information, the medical smartphone will democratize healthcare. Anywhere you can get a mobile signal, you'll have new ways to practice data-driven medicine. Patients won't just be empowered, they'll be emancipated. And he goes on to say they won't have to go to the doctor. Anyone want to guess where Eric Topol practices medicine? Scripps in La Jolla, California. This is California thinking. Well, let me tell you, there's not a single study, not one, of telemedicine that shows it actually does anything, changes patient behavior, gets better outcomes. I could give you many, many studies. I'll just give you my favorite, which was published just 2 years ago in JAMA Internal Medicine. It randomized 1,500 patients at the University of California hospitals, UCLA, UCSF, Davis, prominent hospitals. They were patients with congestive heart failure. They went into two groups, usual care, not souped up telemedicine, and then a group with remote monitoring, wireless blood pressure cuffs, wireless scales at home, symptom management via their smartphone, and reminders to take their medications. And if something was wrong, too much weight, too high blood pressure or heart rate, a nurse intervened and called. After 30 days, no difference in the readmission rate. After 180 days, no difference in the mortality rate. A zero study, negative study. So, high-tech sensors, none. And it's not the only study. I can give you others. Here's a 2017 study, 50,000 patients. CVS is the biggest pharmacy in the United States. They had 3 arms, pill bottles with strips and toggles, right? Just regular pill bottle. Digital timer cap that was on and would buzz when you had to take your medication, and a standard pill box. They randomized 50,000 patients. No differences in the 3 arms in improving medication adherence, right? Having a high-tech digital timer on your medicine did not improve adherence. Now, if you think, as I do, that the fundamental challenge of chronic care management is behavior change in patients, telemedicine is a bad way to change behavior. How do you change behavior? You want to do something different. You want to suddenly exercise, or you want to diet. Is it digital that you go to? I don't think so. So, the key point is that digital medicine can't change behavior by itself. Virtual medicine is never going to replace the physician-patient or the nurse-patient relationship. It can supplement it, but it cannot replace it. And the problem is that most of telemedicine, most of virtual medicine thinks of replacing the doctor. That was Eric Topol's, we're going to democratize medical information. Virtual medicine works best in the background, giving physicians information that they can use in managing patients. So I think that what you're going to see for virtual medicine is rural health, not a problem in Israel, by and large. There are some places, but the United States, Canada, Australia, this is a huge problem for about 20% of the population, live very far. So telemedicine is going to have to solve that problem. It'll be useful in behavioral health. Some patients like not to talk to people, but to talk to machines better. And you can use it for patients who have problems with social settings, don't like to go out into society. MD consults, not for the patient, but you take a picture of a mole. You're not an expert in skin moles. You need a dermatologist. This can double the number of patients a dermatologist can see, not by seeing more patients, but by seeing more pictures and letting the primary care doctor manage those patients. It's also good for situations where you have few specialists, but patients, like pediatric specialties, where there are never enough pediatric specialists, GI doctors, pediatric cardiologists. Follow-up for chronic care. Very good. Minor care resolution. So one of the companies we looked at loved high-tech. What was their most high-tech successful intervention? Text messaging. Woman comes in with urinary tract infection. Give them antibiotics, right? They don't say, come back, make sure it's fine. They text. Any burning after 3 days? Or still having a problem? Or is that wound weeping? Text messaging, they said, is their best high-tech telemedicine intervention. And again, text messaging communication. These are 12. I've only talked about 3 of them. I'm happy to talk about any of the others. I will tell you that, at least in the United States, the big emphasis this year among venture capitalists is behavioral health. Super big problem, adds substantial cost, trying to use new innovations in that space. Now, I want to conclude by talking about the timeline of transformation. If you begin this journey, when do you expect to really transform your care? You know, doctors, especially academic doctors like me, right? We need to, how do I survive as an academic doctor? Right? Not by seeing patients, I have to publish, right? So after 1 year, I need to publish something, right? Otherwise I can't get tenure, right? I can't get the next grant. So we often just lift the lid up. We have a phrase in the United States, is the water boiling yet? So you take the lid off every 2 minutes, you know. It's like your kids in the car. Are we there yet? Right? But if you look at the literature of transformation and change, universally, You can expect some early results in year 1, some in year 2, but the major change happens in year 4 and 5, and culture, completely changed culture, takes 10 years. So you want to change a company, right? What's the biggest problem is you get little successes, you declare victory, and everyone goes home, and nothing really changes. You have to keep at it. Now, to keep at it, you need progress, and you need to show progress over time, but you should also set expectations properly. It takes 4 years. There are many studies in the United States. If you pay doctors differently, how long does it take them to change behavior? Right? Turns out 4 years till you see successful improvement. Is that my next slide? No. If you look at so the Massachusetts Blue Cross and Blue Shield did this 4 years. If you introduce a change in treatment, how long does it take to spread across the country? Not the early adopters, but to really spread. You know what the data shows? Between 13 and 17 years before all doctors are doing. That's how long it took to give beta blockers after myocardial infarction. 17 years to get everyone on board, right? Transformation doesn't happen fast. Never happens fast. Takes a long time, right? We're now just 10 years after introduction of the smartphone, right? And Facebook and stuff like that. Our whole world's now. This is my plug. So all of these case examples are in my book, Prescription for the Future, and I talk about how to implement things, the sequence to implement things. And as I told you, I made a chocolate bar. You know, it's very important to keep yourself level. And I like to do one new thing every year. 1 year I was a chef, chocolate bar. Next year it's super fancy apple juice. Okay, thank you very much. My last slide is we have a whole series of online courses focused on innovation and giving people the skills for innovation, whether it's behavioral economics, or it's process improvement, or it's how do you evaluate an intervention to see whether it's working or not working. That might be useful for you. Questions?